combine with the calcium to form calcium pyrophosphate dihydrate. So this crystal is deposited in joint spaces that have a predilection to osteoarthritic changes. So these pseudo-gout crystals damage include the fragmentation of the bone and cartilage, and the formation of osteophytes and the subchondrocysts. Now, metabolic disorders such as hemochromatosis and hyperparathyroidism and hypomagnesemia increase the likelihood of calcium pyruvate phosphate deposition. So whenever you get someone with a gout, you have to look at these hormones, the parathyroid hormone. Then you have to check for magnesium in blood, because to rule out the risk of calcium pyruvate phosphate deposition in the joint. Then we have the septic arthritis. This one is typically an inflammatory response to a monobacterial infection. Someone might be having a bacterial infection in blood or in the body somewhere, and then it end up affecting the joint, and someone gets septic arthritis. So bacterial entry into the sinus and proteases that degenerate cartilages and trigger hyperplasia of the synovial membrane. So these toxins produced by bacteria with space itself. Actually, it's all the same. It's all about production of the cytokinase, chemokinase, and the proteases in most of them, only in gout which it differs. So we are talking about in adult, the most common cause of septic arthritis is Staphylococcus aureus. So thank you, Mr. Coordinator. I'm through with the pathophysiology of the arthritis.
Okay, thank you, Mr. Chiviran, for that presentation. Maybe in summary, he has been talking about the pathophysiology. So you find out that according to what he has discussed, the pathophysiology looks like a complex process, and it involves multiple cellular, molecular, and environmental factors. And the key players in the development of arthritis, we've heard of the cytokines, and these cytokines pro-inflammatory and anti-inflammatory play a crucial role in the pathophysiology. Then we've heard about the immune cells, like the T cells, the beta cells, the macrophages, and other immune cells. All this also results into joint inflammation and the damage. He has also talked about the matrix metalloproteinase. These are enzymes which participate in the breakdown of cartilages, which is in between the bones. And as a result, this develops into bone destruction. He has also talked about the osteoclasts, and their role in the development of arthritis is that they lead to resorption or erosion of the bones, like they keep on making bones grow small. I mean, erosion, like when he's scratching bones, the osteoclasts, they are just cells in our bodies. So they actually, according to what he said, those are the commonest key players in the development of arthritis. Maybe to add on the pathophysiology, like for osteoarthritis, actually, this process happens as a process whereby it's a step-by-step process which results in arthritis. Like in the osteoarthritis, we start with the cartilage degeneration. As I've told you, as someone keeps on growing, some parts keeps on reducing, degeneration. That's the term which we can use. So as the bones keep on wearing off, tearing, this cartilage leads to break down and loss of joint. And as a result, it results into joint inflammation. And as inflammation sets in, that's when there's that release of those pro-inflammatory cytokines, the chemokines which attract the immune cells. And these at times are the ones which perpetuate the inflammation. Then we have the subchondral bone changes. Actually, as the bone keeps on getting resolved, there's some changes which happens in between the joints. And as this is when the uric acid is deposited in those joints, it acts as a foreign body. So the body will initiate inflammatory process to eliminate the uric acid, which is deposited in the joints. And this inflammatory process results into the other process we talked about, the inflammatory process, the cytokines, the release of crystals, and then as a result, the inflammation of the joint happens. So that's what we call gout. But the initiator of gout is the position of uric acid, which is in the form of monosodium urate crystals. Then you have the chronic gout. Actually, it happens when someone gets cases almost every after some months, it reappears. And in simple terms, the key players in pathophysiology, we have the cytokines, which are the pro-inflammatory, anti-inflammatory, very crucial in pathophysiology. Then you have the immune cells, he has talked about them. Then you have the matrix metalloproteinase. These are enzymes which break down cartilage, which make up the joints. Then also the osteoclasts, those cells which break down the particles of erosion of the bones. So maybe from there, I'll call another discussant, continue with the signs and symptoms of arthritis. Then after that, I'll call another one to continue from there. Anyone ready? Is it
yes? Thank
Madam?
you. Yes, thank you. I've come in.
Okay.
Emma, if you could help me share. Emma, I was requesting help me share on osteoarthritis. I had shared it with you today morning.
Give me.
Yes, Emma there? Yeah, so that's what we call osteoarthritis. It's just all about the wear and tear of the cartilage. I think we should know, I think my colleagues, I'm not going to pass through the physiology again, because my colleagues have talked about it, but I hope people are more conversant with the structure of the joint. As long as you know the structure of the joint, everything is okay, it goes clear. You should be able to know parts of the joint, where the cartilage is, where the ligament is, where the tendon, where the synovial fluid is, where the bursa is, where the meniscus is, where the subchondral bone is. If you know where all those ones are located, then you are able to tell. So if we are looking at, if we can go further, Emma, up. Is Emma there? I think he's busy. I don't know that Emma, I need to first transfer the, because I had it on my PC here. I think Emma is busy. Emma, I was wishing you push up, because most of the things have been said there. Is it okay, Emma? I think it's busy. I don't know what's wrong, but let me try to see that I share it. Emma, let me share. Rheumatoid arthritis, it remains the same. Management for all the other forms of polyarthritis are the same. Are you getting it? It's just the same line. Yeah. So they have talked about the physiology. Yes, please. Yes.
Kusoma chate. Njagala kuvuga. Ndi mu kilasi bampulira banda. Ono mukazi wange temufaayo.
Katonda wange.
Oki olibega. Amale kilasi kanjije tulikole. Kyali kiteggwa. Ngenda kikola. Hey, Mr. Shoka, we are not hearing you.
Are you sure?
Now you clear.
Now I'm clear, eh?
Yeah.
All right, it's okay. Let me continue. So we need to identify that there are factors that can cause osteoarthritis. There are those ones which are modifiable and there are those ones which are non-modifiable. If one of the modifiable factors is obesity, someone who's big, weight yomuntu, you're going to have an increased body weight. By which that weight is going to contribute to a force on the knee joint. Are you getting it?